Right. Yeah.
That's you.
How are you? Yeah.
Never better. How are you?
Good, good, good. Yeah. Thank you so much for accepting this invitation. Yeah.
It's an unmissable invitation.
I'll turn off the volume a little bit. Yeah. Good. Yeah. We'll wait for a few minutes I think, for people to join. Yeah.
Okay.
Mm, mm.
Just let me
So,
know.
yeah.
How much time do I have about?
I was thinking 40, 45 minutes. 45 minutes. Is that okay? Yeah.
Oh, absolutely. Absolutely. I just want to be respectful of the time. And you gonna advance my slides? Is that it?
Oh, how are we? I have Sarah here with me, our chief resident.
I can do that, Dr. Toller, or you can do it yourself. What would you prefer?
I would prefer doing it myself, but I don't know how.
Do you have your presentation up on your screen?
No.
Oh, really?
Let me get Christine. You know, she's
Okay.
good.
Yeah.
They said that I can advance my slides, but I just don't know how.
Oh, okay.
We have a good turnout.
Hey everyone, while we're getting set up, welcome to Grand Rounds. And if you could please sign in so that you can get CME credit and we can know that you're here, that would be wonderful. And in a few minutes, Dr. Jahagadar will introduce Dr. Dean Toller. Thank you.
Sarah is going to make you the presenter. Is he the presenter now? Is he the presenter now?
Nope, I'm still presenting. Christine, let me know when you have the presentation up and I can, do you see an option that you can share your screen?
Do I need to request control though first for him to do that?
If there's not an option to share content, then yes.
Okay, thank you, because that was not there. So, okay. And it says waiting for approval now. I did send it to you all this morning as a PDF if you need to advance for him.
Yes, I have it if we're not able to get this done.
Perfect. Thank you. Okay, it came back to me to request control, so it doesn't seem to be working on our end. So are you able to advance for him and he can just say next slide?
That sounds good.
Okay, that sounds great. Thank you.
Yeah.
Okay.
I'm ready.
Yeah. All right. Great. Well, thank you so much, Dr. Toller, for accepting this invitation. You know, it's my honor to introduce Dean Toller today. He does not need an introduction to this audience. He is the Dean of the Medical School, Vice President for Clinical Affairs, and a distinguished McKnight Professor at the University of Minnesota. Dr. Toller is this remarkable individual who has achieved excellence in all aspects of medicine. He has an MD from Charles University in Prague, a PhD in molecular, cellular, and developmental biology and genetics, and from University of Minnesota. There he also did his fellowship in pediatric hematology, oncology, and blood and marrow transplantation. He's an internationally recognized basic science and clinical researcher with over 200 publications. Many of them are practice-changing publications and published in very high-ranking and impactful journals. He still maintains an active lab and clinical practice and is recognized as a top doctor by his peers for the past many years in a row. The list of his awards and his recognitions is really very exhaustive, and in the interest of time, Dr. Tolar, I will not go over it. But Yakub is really a visionary leader, and today he's joining us to talk about how medical education is changing, where we came from, where we are going, highlighting the new developments on the horizon, and his vision for medical education at the U and nationally. So please welcome Dr. Tolar.
Thank you, Val. I'm coming, to France. I'm coming to a place I know very well. I have, through my training here, and I've been here for the last almost 30 years in different capacities, as Val said. I've been, in regions multiple times, attended there, trained there. I am continuously impressed, with the quality of care and the width of training, with the level 1 trauma, with the heart center, birth center, burn center, cancer care centers, and TRIA, of course. And so it's an honor. It's a privilege to be here. And among my friends, Val is one of the people who actually shared a hood with me in the lab, way back. And he counts into many people that I admire and counts into many people that I learned from. I also have a number of colleagues, and I'm not going to name all of them, but for example, Peter Bachan, who is in pulmonary division, is one of the close allies, and I've always been touched by his dedication to the intensive care medicine and his ability to understand basic science. And Jim Risser, a musician and a palliative care physician as well. Again, one of the people that I trained with, and not only he's a remarkable physician and an expert in logistics, but he's very funny. And I like people who are genuinely funny. And on the other edge of the spectrum, Andrea Walsh, is my partner in co-leadership of one of the Itasca projects. And this one, which I'll briefly mention as a part of the educational bandwidth, is the what we call 1,000 Days, which looks at the developmental causes of disease and has been externalized in the new building that we have in the Shriners Hospital, which is the Institute for Developing Brain. Next slide, please. So I'll start, with the profound humility and deference that I feel in serving this medical school and serving this university, this practice, this craft, and the multitudinous aspects and truly, the life-affirming challenge that what we teach, what we explore, what we heal, and how we serve, what it encompasses. Next slide, please. The past is, for me, a guide. I have looked at history of medicine as many of you did, and I see that there are stages to it. I look at the 4th century before Christ as Athens as a opening in many ways to how we think about science and medicine, and that was the time of the intuitive medicine. The second stage was the empirical one, when in Renaissance and around that time, things started to be layered according to different fields, and then in the last century, we entered the precision, the evidence-based medicine, where the digital data have emerged from this. And then Today, I think we are living through what others have called high-performance medicine, where we can domesticate the digital wealth of data that that we have at our disposal. Looking at a photograph like this, though, reminds everybody, I think, that the people who preceded us were in many ways exactly like us. They were just given a different epigenetics, if you will, in their education, in their circumstance societally, and in their reach for what we actually do know and do not know in the realm of medicine. Next slide. The visual representation of this can be at the year that this medical school was already operational. It's more than 130 years old. The causes of death in the state of Minnesota, and miasma, as some of you would know, is this reference to the noxious exhalation from putrescent organic matter. So a lot of things were unknown, and I again, look at this, from the angle of what the people that preceded us knew about this, and with no arrogance, especially the opposite, with the humility of how much we are missing in the current state of mind, despite of all the glitter and flashing devices that we have at our disposal. It is truly a dynamic perspective of how we care about our patients. Next slide. This is a example of a I have this bag, in my office over there, not mine, but from a physician in rural Minnesota from the 1920s, 1930s. I have a profound admiration for how independent, how autonomous, and how helpful these physicians have been. And I think we have a lot to learn from quite a few of them, and especially the way they were able to channel their compassion in something that can actually be done for our patients. Next slide. The early medical school education at this university, anyway, has been different than what's now. So most of the people that you see in the photograph, the professors that have been leading their specialties at the inception and the first part of the medical school here or anywhere actually in the United States, they were, first of all, they were classically trained. These people would have known Latin, Greek. They would be no difference essentially from their scientific training and vocational training, if this were in surgical procedures and so forth, and they would be reliant on physical diagnosis in ways that I think is a challenge today when we have portable ultrasounds and can scan everybody in a couple of minutes. And the ability to pay attention with all the five senses to the family and the patient and the community, is something that we better keep in mind as we advance the medical education. In addition to their ability to be widely educated, to not having a narrow focus from the early on, I think it was also the acceptance that even boring subjects need to be part of your education as a physician if you want to be educated. And we have moved away from this because, for reasons that are a little obscure to me, we think that whatever makes a student happy is a good thing. And we somehow have this, in my opinion, warped idea that the students themselves can actually know what they need to know. I can tell you from my personal experience that the person I was 30 years ago, or 40 years ago for that matter, is very different from the person I am today. And I certainly would not be in a good advisor on what I should be studying and how should I be studying and what is the level of competence that I should be achieving at each individual stage. I assume that it is similar, that for medical students and PhD students that are a generation younger, or two, than I am today. I also think that some of the societal features that we are seeing are a reflection of the fact that we have lost, and I'm not judging it as a positive or negative, but we do not have that that common platform of education that would enable articulate, sophisticated discourse across the society, intellectuals or otherwise. We just don't have this. So a lot of the things that we are looking at, and I'll get to some of the examples in the COVID-19 examples, will become more understandable, at least to my feeble mind, if we consider that we have not been able to achieve a replacement for that common ground that has been a reality for our predecessors. New slide. The lectures and practice, again, one can look at this, with a smile, but I look at this as a sort of concentrated, intense effort. New slide. And how they trained. And some of these pictures that are from the lecture halls from way back, more than a century and a half back, perhaps, are, again, as real to them as our high-tech things are for us today. New paragraph. And they organize themselves. This is a yearly yearbook of the students, at the medical school at the beginning of the last century. And again, they were alive to the environment that they felt, was on the forefront of advancement, the same way as we are. Next one. And then what happened in 1910 is a threshold study from Abraham Flexner, who's at Princeton, and I'm always reminded of this report when he traveled across the United States, visited different medical schools, and famously for us, has said that the University of Minnesota Medical School is one of the first, if not the first, that was able to pair education and care in the same training. He meant mostly the residency training and so forth. And for me, this was always a insightful work, as some of his other works. And he wrote a book about usefulness of useless knowledge, which I can only recommend to you because it comes from a perspective of somebody who was a boss of Einstein. Just imagine this for a minute, that Einstein reports to you. That's not an easy leadership role for anyone. Next one. This is the bag that I was talking a moment ago, and as we are getting to the points that I want to make about the current education, I just want to turn back a little bit and recognize that the ancient Greece and Roman and in fact Arabic around the turn of the first millennium, medicine is quite different from the medicine that we have today. And the beginning of the medicine actually was not, in my opinion, in my reading of the history, it was not the medicine itself. There's a discontinuity because what happened in my reading of the history is that it started from physics. It's really Newton who started on the path where we are right now, and it's nice that on this day in 1609, Galileo Galilei for the first time used a telescope and looked at the moon, for example. So that's where this understanding that comes to us almost as an innate ability that there are natural laws that apply to humans and non-human objects as well, comes from. And on the back of that was chemistry. Chemistry was the next one. And then after that, biology. How do you apply the lock and key, chemistry structures to biology, how ligand binds a receptor, for example. And only on top of that came medicine. And Louis Thomas, who was he worked here in Minneapolis in the 1960s and 1970s, immunologist, and then led Sloan Kettering in New York for a long time, wrote a book called Youngest Science, where he describes it after the large area of time of therapeutic nihilism, which was Osler, and many others, which basically was guiding the physicians, don't do anything to the patient, because most of everything that has been done before has been either too pedestrian or, frankly, dangerous to the patient. So restrain yourself to the back, that you see on the left, where you can actually do something, as you have anesthetic, as you have antibiotic, antisepsis, and that's all that's happening around that same time. Next slide. So now, as we have advanced in this and accumulated that knowledge, and one of the best inventions in the history of mankind, in my opinion, is a book. This is the codex that comes, it's a better thing than a scroll. It lasts longer, and with the printing press, of course, the information can be gathered in a way that is unimaginable, I think, for the generation that preceded it. And the educational wave, followed on upon this. So getting people to memorize a lot of facts, and then, next slide, defend that argument in front of typically a group of professors, that has been what established, I think, medicine as one of the highest achievements of mankind, sort of by the middle of the last century. And in fact, when I was at the training, I went to medical school. It's a little different in Europe. When I was 17, it's a longer training. It's about 6 years. That's exactly what we did. I don't think that I've taken a single multiple choice question test in my whole medical education. And even though there certainly were times, when I thought, this is a lot of things to know. The fact that it's almost necessary to be able to memorize a lot of things, for as uncomfortable as it may be, to have the right retrieval of that information. And I'll argue in a minute, that the Google search is not equivalent to that capacity. And also, I think the ability to transform that information into a defense of whatever you want to try to argue for or against, is actually incredibly helpful tool in science, clinical care, or leadership, for that matter. Next slide. So what we have moved into is first the stage, and that would be the beginning of the century, SATs first, and then MCATs and so forth, were the tests. How can we get people to actually stay on their path of education? And the SAT, as many of you know, started as a tool, on the East Coast to keep people in the right people in colleges, and then MCATs a little later to prevent that phenomenal attrition that has happened in the medical education in the United States. I can. As far as I know, it's still the same in Europe, and then the countries that I follow are not all of them, but France, Germany, United Kingdom, Italy, for that matter. There's still dysfunctions, and so a lot of people can get to the medical school or law school or any other school, and it is understood that a lot of them will not finish. And there's some wisdom, I would argue, in that, because how would you know in advance what kind of a proxy are you going to use for people who are actually fit for this? And can you perhaps get the knowledge from the system of education by putting people in that system, and then let them by whatever results, outcomes, and behaviors they show, gauge how fit they are for the profession that they have chosen. Case in point, when I came here to get my PhD in '92, we still have the pyramidal system. There were 24 of us that started in my class. 8 of us only finished, and that was sort of given. This is very, very different from what we do today. My colleagues in the College of Education and Human Development here at the university tell me that the MCATs and SAT are one of the most unbiased ways of getting people from different backgrounds, different languages, different, all socioeconomic status layers to really be assessed by this. Next slide. So we went to the point that we thought that you need to know a lot of things to be able to safely get into the operating room, get into the ICU, and get into clinic. Next slide. To the point that we said, all right, all this information can be moved from the analog, when you have different, shades of information, if you will, to the digital when you code it and have essentially a binary way of searching through these engines. And I think that all of us have been enamored in one way or another with that ability. And I remember when I hear an echo, but if people are not bothered by that, that's fine. But somebody is not on mute. Thank you very much, Dr. Wilson. I think the first internet, the World Wide Web, in 1980s, beginning of 1990s, and then of course the iPhone moment, in 2007, when we realized that we can do this in this little computer in our pocket, and it paralleled the human genome understanding. It paralleled a lot of, obviously, understanding in oncology and cardiology, and almost every part of medicine would be affected by this. And what we have now is next slide. What we have now is more the opposite of this. In my opinion, is this the iPhone can be, either, an access to all of these wonderful databases, and it can simultaneously be an interruption technology that has disrupted the way we think and the way the predecessors of ours have thought. And perhaps there is a loss of some wisdom and some virtue in this setting. So that is why I have and I'm still being laughed at by my children. That I have no social media. I don't go on this. I'm not a savant, but I don't watch television. I don't do this sort of a rapid sequence attention jumping around because it's at least from my standpoint, it's a waste of time. So the filters, the complaints that people have, students included, and that's why it's so important for the education is not, the wealth of the digital data. In fact, for artificial intelligence, which is another interest of mine, and machine learning, the drawback is if you have too few data, not too many pieces of data, on the personal thinking, epistemic way of us individuals, it is really a filter failure that I think is the biggest problem that we are that we are facing as far as information go, because Claude Shannon was right. Information is neutral. It doesn't have a positive or negative value. It is really how we achieve some kind of affluence across the fields that we are interested in. And speaking of that, and Bao, I think, would agree with this, that it is not quite clear to me why there are a group of basic scientists and group of clinicians when the subject, the human body typically, and whatever lives on top of the human body, is the same task. And I think that the reason I am able to keep my R01s and be somewhat relevant in basic science has a lot to do with the fact that I know what to do in the clinic and OR, and the other way around. I think I'm a better physician because I actually am fluent in the basic science and know what DNA is. So I think that there's another drop-off of quality that may come with less rigor and less wealth, less openness, in the education. Next slide. So this translates into how we select the students, medical students and others. Now there's a very, very significant move to the soft skills and the interviews that are looking for new, perhaps more important, perhaps complementary virtues in a future physician, and that being creativity, grace under pressure, communication, empathy, and so forth. What is that's unquestionably, is a significant part of everybody's doctoring, and the personal, of course, is always, almost always, I hope, a part of how we present ourselves to our patients and their families and communities. The question is how much of that is truly helpful to our students, because one thing that is data driven is that the interview-based system of selection of medical students is actually more biased than it is the classical MCAT and SAT and other choices that actually have preceded this, and it's at this time is the biases of the interviewers rather than the biases of the people or the system. Next slide. So I would argue that there are several layers of humility, that perhaps that there is a cultural humility that is necessary, but epistemic as well. The ability to understand the knowledge at the full scope of it is something that we better translate to and present to our students, so that they do have the ability of the at least two forms of attention. One being this hyperactive attention, which is common to almost all of us. Again, that has to do with some of the iPhones, some of the technology, some of the fact that you can search up to date, and be a physician for a day. And we all have seen all of these patients that come to us with diagnoses, and typically incomplete, let's put it that way. And that deep attention that I think is necessary for any real advancement in the care of single patient or a ICU unit, or long-term projection of where we are going. And I would like us, you, me, and everybody else who surrounds the new generation of medical students, trainees, and so forth, to impart this, on that class as well. Next slide. So the unique obligation and privilege, honor, really, of the University of Minnesota Medical School is that 70% of physicians that practice in the state came through this school. Similar number is for pharmacists and nurses and other health science professionals, but that's an incredible exposure, I think, to the talent and diversity, which is the wellspring of all excellence that I know, and again, an obligation. Next slide. That gives us an opening into what we all know, which is that physicians tend to be drawn to the areas of density of challenge, density of complexity, density of new areas, and the numbers that we have been presented with are certainly a good guide in the greatness of the task in front of us. The patient-centered care is unquestionable, and I want to be absolutely clear about the compassionate care. This is something that I think, in the time when my residents, which always irritates me if they do that, would have a diagnosis from the computer before they have seen the patient. I have a bias for physical diagnosis. I actually do think that people should be able to have not just pass the medical school physical diagnosis, but there's something about being able to use your senses to complement whatever tests and imaging we get. And then the unquestionable role of a physician is to be present, period. Present with the patient, because she wants to have us present. And a lot of things that are more bureaucratic and more artificial in our lives, from Epic to billing to surveys to trainings, and all of that is truly distracting us from that singular talent that a physician has, which is alleviation of human suffering. I want to also share that, at least for me, this is almost flip-flopped, because Bal knows this. I'm interested in a lot of other things than outside of medicine. But if I have a young woman with leukemia, which is my typical patient, I would be spending clearly, more time with her and her family than than allowed by, metrics and all that stuff, because it matters, because it's, what matters to me and what matters to them. And I would say that all the chemo and transplant and radiation and all the side effects and all that stuff, it's about 10% of what I do. 90% of that is, I have to explain to her that she's going to lose her hair, that she may not have children, and that she's going to lose 2 years of her life facing something that even under a circumstance of magnanimity is unfair to her. And from that, I get learning much more from Edward Hopper and Maria Callas than I get from any medical or scientific book that I know. And the bilateral aspect of this, I think, is, at least for me, that I learned how to live my life more from my patients than from almost anybody else. So this is a place for many of us that is, again, life affirming, life enhancing, and sort of makes sense of who we are as individuals and as groups. Next. Now, the challenges as a land-grant university that we have are, in my opinion, glorious. So one of them is having enabling access to high-quality medicine to people who don't live close to big cities and big hospitals. So that's where the rural and greater Minnesota comes into. We are grateful to have 2 campuses, as you probably know. We are one medical school with 2 campuses, one in Duluth, and a lot of work that we do there is oriented at on the whole United States. It's 65 million of Americans that live in what's called rural areas. That's a lot of people that need to be taken care of. Next. The pipeline is also bilateral. It is really to get people from small cities into the medical school so that they then can go back and serve their communities in that way. Next. So let's spend a couple of minutes on COVID. Not to rehash, and this is not a COVID talk, but this is the New England Journal picture that I saw in the end of December of last year. That many of us have sort of repositioned our thinking about, what is this going to be, and what are the lessons that we have in education that we have gained from being a part of the COVID-19. Next. The first thing is that one of the most important lessons, at least for me, was that we have agency. We kept agency at the time when a majority of the society would be in this lockdown mentality. We actually had work to do. We trained for this, and many of your clinical teams and other clinical teams, ours included, this was our finest hour. This was when this enormous amount of medicine has been put to service to people that actually needed it. Next slide. And I'm profoundly grateful to all the teams. What it also taught us, I think, is how, and I mentioned some of this a while ago, how different society, how differently society responds to some of these things. And and sometimes, it was borderline unbelievable, where you saw all this transferred blame and scapegoating and false expertise and sort of these boxes of fortified emptiness, in this. And you thought with White Queen, you thought, believing 6 impossible things before breakfast was normal. So out of that, out of that service to the society, next slide, emerged, I think, another lesson for me, which came from the students themselves. At the White Coat ceremony last week, I spoke with Sarah, which is one of the people who started this, when the students repurposed their time and said, well, how can I help in this? I cannot, I don't know how to manage Vent yet, but, I can do something. And these COVID sitters was a glorious example. Next slide, of what can come out of the pandemic like this. The innovation was different. What I learned is what's known in engineering as reverse innovation, which is essentially starting from the front line and then bringing deconstructing it into something that can be done better. And that's where, some of the trials, some of the AI algorithms, some of the, the convener is the little $150 worth ventilator on the right. Next slide. And the production lines that we had with the booth, with the PPEs that we built with the College of Science and Engineering. Next slide. And the ability that we were able to use the M simulation. We have 2 floors in this new building that is simulation center. Next slide, where we were able to model, not just the how you behave. Next slide, in the environment of this, but how do you actually do the donning and doffing of the PPEs in a safe way? Next slide. That we can do all this, and I'm profoundly grateful to the Regents Hospital, for accommodating the trainees and learners in this stretched period, and everybody else who has been able to help along. Next slide. The lessons. Lesson number 1 for me is the team. I always thought that thinking is not, even though people, myself including, make that mistake that you sort of sit down alone and think deeply, right? Well, yes, it's important. There's the deep attention that I talk about, but almost everything that really works in the areas that I follow is coming from relational, engaged, honest group team, thinking. So thinking is not a solitary activity at all. And in fact, many improvements that I have seen are happening as a byproduct of collaboration and thinking together, having the ideas recombine and change rather than the goal of it. That's another fallacy of this, that all the strategic plans and all these, things that are somewhat, underperforming, if you will. Next. The virtual visits, great equalizer. We were talking about virtual visits, as you were probably, for years, as long as I can remember. And then we, like this, we've done this in 3 days, and it can be done. And yes, it is phenomenal for Greater Minnesota to have that capacity. Next. The future, in this sense, I think, will be determined by several other realization out of the COVID and out of the last couple of years. First is bioengineering. I like math and physics, so it came naturally to me as an oncologist to look at with a large group of people, the physical behaviors of cancer cells. So if you remember Varmus and Bischoff, when the oncogenes were discovered, cancer was a disease of a cell. One cell. Then when Vogelstein and Kinstler came around, realized that yes, but you need that cascade that they mapped in the colon cancer. And then I still think should get Nobel Prize for this. They didn't. And then of late, we realized that cancer is really a disease of a tissue, of a stroma, of an immune system, of that interplay. And that's what the panel on the left is looking at, how the physical behavior of cells in metastasis or inception of cancer, how this works. And on the right, to remind me that the genome engineering, which is one part of my lab as well, in sickle cell anemia and other conditions, will again be the engineering part of medicine. Next. The virtual reality and the modeling that I a little bit outlined for you in the M simulation sequence is really more than that. It is with all the ability to model things at the real time, we will, in my opinion, get data. And the data platform, it's more like driverless cars. There are really computers on wheels. You get a platform of data from a sensor like a pacemaker or AFib sensor, in the vertebral artery. That is a very different concept. Next. That gives us back to the big data. So I personally see the next step in this being able to grab and focus. That's really important. Focus the data that we get from the wearables. Anything from Fitbit to any of the devices that we implant in people, and complement this with ambient intelligence, something in Medicinized Home, that we would have sensors that we can say, how the person moves, whether she took her medications and so forth, and put it in one comprehensive, coherent story that would essentially be a real-time, always-on physical that will then be presented to the physician with choices of, have you thought of this, or how about that, so that we don't have medications. I'm not saying that you do this or I do this, but it is certainly something that we are all biased in a way. Do we prescribe medication because we are comfortable prescribing them, or do we prescribe them because they are the best for the patient in front of us? And I hope that most of us would agree that there is a symbiotic agreement, relationship between the artificial intelligence and the human intelligence that really make it better for our patients. Next. The compassion that I talked about and the community involvement is gonna be another game-changing, I think, perspective. It's not as much the goodness of heart. I sort of assume that doctors are sort of warm-hearted and magnanimous and all that virtuous stuff. It's more that the social influence on the disease, is really what is fundamental in how the patients come to us. Next. And that brings me to the developmental causes of disease. The first example is the realization that the disorders of despair that have been described by others, called by others maladapted adults in their 30s, have a series, has actually incredible mortality, increasing over years from addiction, from obesity, from suicide, and so forth. You cannot possibly fix this, quote unquote, at that time, but it's happening on a societal measure. You have to start earlier. And the idea behind this new Masonic Institute for Developing Brain is that you need to intervene at very early age when the brain is plastic and when you can actually do this. And there is a good measure, these are these adverse childhood events. And if you have more than 7, the chances that you will not make it into the normal societal connections is almost 100%. And you can prevent this. We can, with interventional psychiatry and interventional, which is interventional in a way that you draw something on iPad kind of interventional, there's no blood spilled, is the concept that I think we are ready to advance. And the opening is in October, so if you're interested, just come and see us. Next, the second part, which is under development now, is in geroscience. As many, have realized that cancer risk, the major cancer risk is age, right? Much, logarithmically higher than any behavioral smoking or anything genetic can be. And simultaneously, the heart disease and dementia and so forth, all of these things, remarkably, are a function of immune system, which is my favorite system. And if you pair together the immunosenescence with the senescence of the tissues and the cells in it, you can apply what's called senolytics. And I have a phenomenal group here, the Medical Discovery Group, with Laura Niedenhofer, that works exactly on that. How you take out the senescent cells that are then triggering and exhausting immune system, and how we can put it in this. So our students need to grab, in my opinion, these five components, in this. And I'm not saying that everybody has to know everything, of course not. But if you say the bioengineering, the engineering components, the virtual reality, the big data management, the community engagement, and the developmental causes of disease, that's a pretty good list. Not too large, not too small. I always like, my teams to be more than muses and more than graces and fewer than muses, rather. That fits about, that's manageable. Next slide. The preventing of the future is almost certainly a hopeless thing, because you cannot predict technology, so you cannot predict future. That's about, as much as we can, say about this. And if anybody hesitates on this, again, imagining, what a future would look like without World Wide Web or without iPhone, or for that matter, all the strategic plans that all these organizations, including mine, have done in 2019 with this 2025 strategic plan, and then COVID came, everything changed. Next slide. And I'll end up on the white coat ceremony that we had just last week. great time, to see the talent, the generation. But I think, next slide, great obligation at the same time to recognize that the compassion is essential, but science, technology is going to be really the best version of compassion that we can present to our patients, and that there is a certain rigor and certain empiricism, certain humility that will prevent us from falling for illusions that, in my opinion, can be harmful in the future. Next and last slide. I would end up on thanking everyone, Bal and you all, and I would argue that the people that you see on the slide in front of you are the smallest denominators of the moral force that education and medicine presents us today, and that the goal and the quest of the school is to be this decision architecture and embodiment of reason to chaperone our craft to its next level. Thank you.
Do you unmute? Yeah. Thank you so much, Jakub. That was excellent talk. Great overview. One of the biggest takeaways for me personally was making use of all of your 5 senses, and not only the visual sense and your thumbs to seek knowledge, and applying it to the patients, and all the subtle things that you talked about. 90% of the learning being done from the patient and the families. I think that's a very important takeaway message for all of our students and everyone. We have a large audience, and I'm sure people have lots of things that they have taken away from the talk and lots of questions probably. So we'll open this for discussion now. And is everybody unmuted? Or yeah, I think you can unmute yourself when you have a question.
Dr. Toller, this is Ellie Gertner, Chair of Medicine here. Can you hear me?
Yes, sir.
Wonderful. First of all, thank you very much for your leadership. And on a personal note, thank you for not overturning any of the recommendations from the Promotion and Tenure Committee that I sit on, because we had problems with other deans who did. So thank you very much for that.
You're welcome.
Having gone through a very similar training program that you did with oral examinations, and having learned from crusty old clinicians. And of course, as you know, I started at age 2, so I've been in this for close to 4 decades as well. I was 2 when I started. Several things strike me, and I think Bal mentioned this as well. Number one, we really should get the point across that 90% of the diagnosis you should have in your hand after history and physical examination, and I agree with that. Experience counts, and I think my major concern is we do not demand excellence from our physicians and our trainees these days. So Bal makes these unbelievable diagnoses because he pushes himself and he says he wants to be an excellent physician. And I'm afraid that I have seen over the years that we are not demanding excellence. And it might be, as you say, because, and by the way, I do not watch television either, etc. But I think my major concern is that more than anything else.
It's very well said. Thank you for this. I agree wholeheartedly. The only thing I would say from my personal experience and the teams that I served over the years and decades, if you don't demand excellence, you don't get it. You just come and say, this is what my expectations are. And of course, you better lead from the front and be able to do this as well. That's why I renewed my R01 last year. So that people actually get affirmation, and but also a directive that this is what it is, not complacency.
Thank you.
You're welcome.
About or comments about education here, where the medical school is going. Anybody in education has any other thoughts, questions? Yeah.
Hi, Dr. Toller. This is Kelly Frisch. in education. How best, thank you for that presentation. It's always, it's fun to hear the history and where we're going with education. How do you see us evolving even better as partners from health partners in the university? What can we focus on moving forward?
Thank you for that question. That's excellent. You know, the relationships are paramount. I think, you know, the fact that we do exchange trainees as of now, the fact that we have, as I mentioned, Andrea Walsh and myself, you know, we interact almost weekly in one way or another. You know, are good sort of lanes or avenues of thought and avenues of getting further to really get to the next stage. You know, I think would have to be much more intentional, similar to the demand for excellence. You know, the demand for the next state of what that means on the institutional side, whether this is a level 1 trauma collaboration, whether it's a burn unit collaboration. You see, getting people engaged in doing things, there's no substitute for it. No, and you know, I am one of the people who, as much as I like to think about stuff, I really try to discipline myself and my teams to stop talking at one point and start doing. So my answer to you would be, you know, have a handful of things that would be advantageous to both organizations and get them going. I know that this is a little difficult virtual. I would much rather be, you know, where you are, you know, you are not in the auditorium, but somewhere, you know, where we can see each other. But also, you know, I'm very open to any kind of questions or comments, especially critical ones, if there are. You know, my email, you can Google me. You know, I unfortunately cannot hide under Iraq anymore. So I think, you know, Bob, you know, or anybody can, you know, share my email and be happy to continue the discussion in that medium.
Great. Thank you so much again, Dr. Tolar, and thank you everybody for joining. I think we are just about out of time. So again, have a wonderful day. Thank you.
Thank you, everyone.